Thank you for joining us tonight. We're going to be presenting Dental Sleep Medicine 101, which is a series or a part of a series called You Need Sleep and So Does Your Practice. Dr. Guy Yatros is going to be presenting tonight. So, Dr. Yatros, I'll let you take it over from here.
Well, thank you, Lisa. And Lisa will be on afterwards to help monitor any questions that come into the chat. She'll monitor those. We may answer some along the way. And certainly at the end, we'll try to get to the majority of the most common questions. We've got a really huge group tonight, which is great. Thank you all for taking the time. I'm Dr. Guy Yatros. I'm a dentist, but all I do these days is help patients with sleep apnea with dental devices. I'm a diplomate for the American Board of Dental Sleep Medicine. I'm also on faculty for the University of South Florida College of Medicine, where I help train the fellows that are about 3 fellows a year becoming sleep doctors, and we work with them about how dental devices work into the curriculum. I'm also the founder of New Concept Sleep, so these are some of my conflicts of interest, although I don't think they'll come up later on in the presentation at all. My 3 offices here, I live on Anna Maria Island in Florida, and we have an office in Sarasota, Bradenton, and Tampa, where all we do is help patients with snoring and sleep apnea of dental devices. I've been doing this over 20 years, and I've been doing this exclusively for over a dozen years, pushing 15 years now. So one of the other companies that I did help found, and now I'm the chief clinical officer for, is Dental Sleep Solutions. And Dental Sleep Solutions is a company we put together to help dentists who want to do this in the United States, to put all the puzzle pieces together, from billing to a big meeting we put on called the North American Dental Sleep Medicine Symposium, to our software. And so if you want to know more about that, Lisa can tell you more about that. I don't think it'll come up as a conflict of interest, but I was the founder. I don't own the company anymore, but I am on staff as their chief clinical officer. And then only the conflict of interest I might have, which won't come up at all tonight, but if you're on Anna Maria Island, look me up. I'm a partner in the Freckle Fin Irish Pub, and I can say this, that we have the best Reubens and coldest beer on Anna Maria Island. So look me up if you're ever here. There's my email for you. So I'm going to get started today. And again, DS3 is sponsoring this, so I appreciate the sponsorship from Lisa, and she can talk to you more at the end about what they do if you really want to do this in your practice, how they can put it all together. So I've talked to tens of thousands of dentists. I've been doing this for over 20 years. I've lectured for almost as long as that, talked to thousands and thousands of dentists. And what I like to start off lots of my lectures with, and if you want to see me in person, by the way, I am doing a course in Las Vegas in the fall. We can give you the information on that. And what I like to do when I do in person is I ask all the attendees, I say, how many of you all screen all of your adult patients for oral cancer? And raise your hand up. And everybody raises their hand up. Of course, they're dentists, they're going to raise their hand up. But I asked them to keep their hand up if you found at least one patient last year who was at risk or had oral cancer. And so a lot of the hands stand up. And I say, keep your hands up if you found 2 patients last year who have oral cancer. And some more hands drop, but still some stay up. And I've done this for thousands. I'm sure it's over 10,000 dentists and dental team members that I've done that with. And the most I've ever found, that there's one person left that was holding their hands up, was 6, and these were general dental offices, not oral surgeons, that a dental office had 6 patients who had oral cancer. And so, gosh, that's not that many, but it's certainly significant to those 6 patients. And the reason that is because the incidence of oral cancer in the adult population is maybe near 1 in 1,000. So if you have 1,000 or 2,000 patients in your office, you're going to have 1 or 2 years that have oral cancer. So the math adds up. But the more important part of this exercise, and Lisa's been around when we've done this, if we had cameras, you could see her nodding her head here, I think, is that I can see you, even though I don't see your picture there, that the more important part of this is, why do we screen our patients for oral cancer? And there's a point to this, I promise, coming up fairly quickly, is that, and a lot of things come out. People say, well, because oral cancer is deadly, because we might get sued if we don't do it, because we love and care for our patients. And ultimately, someone will say it's because it's our job to do that, and it's in the oral cavity. So I think those are all important things. And I think you might see where I'm going here. The next question I usually ask, and if you come to the course in Las Vegas, I'll probably do this again because I love doing it. Say, how many of you out there screen all of your adult patients for obstructive sleep apnea? In other words, you ask them questions to see if they're at risk for having airway problems at night. And like a lot of people's hands will stay up, and a lot will go down because most offices, a lot of the dental offices aren't doing that. And I'm going to tell you, if you get nothing more out of this hour we have tonight, is you're going to see that your job as a dentist to at least start looking at your patients and deciding on which ones might be at risk for having obstructive sleep apnea and help them discover if they do or not. It's becoming our job to do that. But I have the audience raise their hands, and the ones who keep their hands up and are actually screening for obstructive sleep apnea, I ask a slightly different question. I say, how many people did you find last week? How many of you found at least one patient last week with obstructive sleep apnea? And all the hands stand up. How many of you found 2, 3, 4? And you'll usually find 3 or 4 people who found 3 or 4 offices who found 3 or more patients in a week who have obstructive sleep apnea. And that's because 1 in 5 adults has apnea in America, 20%. You might want to remember that number because there'll be a little quiz later on. Try to make it easy for you if you want to get your CE. But 1 in 5 adults have obstructive sleep apnea. And then the more important part, and I can see Lisa nodding even though I can't see, is that why do we do that? Why should we as dentists do this? And I can tell you it's the same reasons. We care for our patients. It's significantly life-altering. It's our job to do this, and the oral cavity has a lot to do with it. And you know what? We might get sued if we don't. I think that's coming down the pike. So I think that'll make more sense to you in just a few moments. And I think we want to start by what is the definition of apnea? Apnea is just you quit breathing. That's what it means. But what we have to consider is how long is that? And we've defined that as a cessation of breath for 10 seconds. Now, when someone has an apnea, it's because you fall asleep at night, you get really relaxed, and all the tissues start sinking in on themselves. I consider it kind of like a balloon. And as that balloon starts, collapsing and a little air goes out of the balloon, that's when it collapses. So an apnea is not really holding your breath for 10 seconds. It's more like letting air out is what happens at night. And then as the patient's breathing out, they quit breathing. So you can't see me, I can't see you, but I hope you'll take just 10 seconds of tonight and play along with this next exercise. One of the last times I'll ask you to play along. And I want you to know what an apnea is. And so I'm going to let you breathe a little air out and then want to quit breathing for 10 seconds. Please play along if you can. So here you go. Breathe some air out and hold your breath. Now, I'm not going to hold my breath because I got to keep talking, but I hope you're doing that at home. And if you are, when you get to this breath right now, you're going to notice some things. You're going to notice that your heart rate's up. You're going to notice that you had a little anxiety, a little stress. Your blood pressure probably went up. That's what you can help your patients with. And I think one of the things that we kind of downplay what dental sleep medicine is, we call it dental sleep medicine. Well, it has to do with sleeping and it has to do with dentistry, but really it's about breathing. And Lisa, I don't know about you, but do you like to breathe?
Yeah, it's pretty necessary.
Pretty necessary. I mean, breathing is the fundamentally most important thing that we do.
Yeah.
And so our patients who 1 in 5, 20% of them aren't breathing at night and they don't know it. Maybe 10%, maybe 15% of the patients that have this know they have it. So that's what we can help our patients with. We can help them understand that they're not breathing at night because most of them don't know it, and help them breathe better. And so it's really dental sleep medicine, but it's really helping them breathe. And if there's not anything more important you can do with your time than to get involved in this if you want to help your patients. So there's the opportunity. If you want to get involved in dental sleep, we're going to do something really worthwhile. But let me give you another reason, because I know dentists want to do the right thing, but dentists also care a lot about money. And I don't think it should be the only reason you should do this. But I got some bad news if you're in the United States. I know we have some international dentists out there today, but I don't know how it is in other countries. But this was published by the American Dental Association last year, and then a recent update this year. So you can go look up this information. It's a lot more detail than I'm going to share with you. But the bad news is, no matter whether you're looking at the ADA survey or the Bureau of Labor Statistics, the net income, so how much the dentists are putting in their pocket from 2010 to 2023 has gone down. We're making less money than we were over 13 years ago. And what's really disturbing, in the last 2 years, we've got this dramatic decrease from 21 to 22 to 23, 10%. I'll show you that slide in just a minute. So dentists are making less money. Well, why is that? Well, it's because we're not producing as much? No. The production's up 3.6% if you look at the slide here. The actual amount the dentists are producing. So the gross revenues are up, but the expenses are greater than the revenue. So 6.7% is the overhead. So our overhead's going up more. And so what did that equate to? Well, we're busier making less money. So in this same article you can look up from the American Dental Association, they asked these dentists since 2007, how busy do you feel? Like you're overworked, underworked, just right? Look at it. The last 2 years of the survey, 37% of the people feel they're too busy. They're overworked. They're busy as they want to be. Okay, that's great if you're making more money, but that's not the case. It's the busiest dentists have felt in over, 13, 14 years. And so the take-home message from this survey is that the net income has gone down. 7%, 21 to 22, 10% in the last 2 years. I mean, that's not good. Well, at the same time, the expenses are going up. So the revenues are going up some, but the expenses are surpassing them. And so at the end of the day, the dentists are actually working longer hours. They're doing more dentistry for less money. And here's where I just almost have to chuckle. It's called margin compression is what the word they came up with. Lisa, you manage quite a few people at Dental Sleep Solutions. How about if you go to your team members and say, listen, folks, I got a proposal for you. I'm going to have you work more hours, longer hours, more hours. I'm going to pay you less. Don't worry. We're just going to call it margin compression. It's going to be okay. I mean,
that would fly over like a lead balloon.
It would fly over like a lead balloon, but that's what we're doing in our dental offices. So here's the good news is I do believe dental sleep can not only help your patients and do something wonderful for them, it can help this margin compression that we're getting. But first, let's think about what it is that we do as dentists and what we have to change. Everything on this screen, these are the same type of occupation. You can see the dentist right in the middle, bottom center. But look at these other occupations. We've got pilots, truck drivers, surgeons, plumbers. I know these guys over here shoveling dirt. They all have something in common. And what is it? Well, I'll tell you what it is I call all these jobs laborers. You've got to be turning a wrench, holding a airplane yoke in your hand, or driving a truck, or having a high-speed drill in your hand, or you're not making money. You're not Garth Brooks getting mailbox money. Okay, it just doesn't work that way. So we only make money when we're actually working on our patients. So I think we all understand that. That's one of the things. We make good money, but how do we make more money? Well, you've got to analyze what your time is worth. And Lisa, you do a lot of consulting.
Yes.
I would say that when you ask these dental offices, do you know how much you're charging per hour of your time? Do most of them even know this?
Most of the time they don't. They don't know the cost of doing business or their time per hour, typically.
You don't. And I can help you analyze this. We can help you analyze it. The good news is you don't have to go into some big detail about it. I think you just need to understand the concept here. So if you want to make more money as for your time, for your efforts as a dentist, we've got to become more efficient. So let's just kind of look at what dental offices are doing. Now, I took these fees. I looked at three things, porcelain crown, two-surface composite, and molar root canal. And I took the fees, if you see the middle column, $1,386 here. These are fees, I think, 2 years ago, average fees by the ADA. So don't worry about what the fee is. Put your own fee in there, whatever that is. And then I took the time. I haven't done general dentistry, in 14, 15 years. But back when I was doing general dentistry, it took me about an hour total of my time to do a crown. So if I use the ADA fee, $1,386, then I was making about an hour of gross revenues per hour of time. Okay, you plug your own fees in there if you kind of want to figure out what you're making. A two-surface composite, 20 minutes was pretty fast. I was pretty good at it. That's pretty fast, I think. Maybe you can do it quicker, but hey, I'm making a little less money if I go by the ADA fees on that. And then a molar root canal. Now, Lisa, I'd have to adjust this to infinity because I didn't do molar root canals. It would take me 5 hours. I'd be making, more money as a paper delivery boy probably. But, for those of you who can do good molar root canals and are good at it, maybe you can do it in an hour. And the average fee was $1,065. So you get the idea. It's $1,065 an hour. Mm-hmm. Now, I'm going to use a couple of things that I'm going to throw at you is the average fee for a dental sleep device and then the dentist time. Now, Lisa's got a vast background in billing. She's been in billing for 25 years?
A little longer than that, but we'll go with 25. Yeah.
Yeah. So she started when she was 12, so that's okay. But so Lisa's got the billing, and Lisa, I used an average fee for a dental office to provide a dental sleep device for patients of $2,000. Being in charge of billing, would you
Mhm.
say that that's really on the low side of what most offices actually collect per case? Would you agree with that?
Yes, I do. I agree.
So I'm using a $2,000 in my office. It's over three. Most office it is. So I'm going to use $2,000 as a low fee just because I don't want to overpromise and underdeliver something. We want to do the opposite of that. And now I can tell you this other part as far as dentist time. I've trained thousands of dentists across the country. Not the first time you do this. The first time you do a crown, it takes you 3 hours. First time you do a dental device, it's going to take you a while. But if you put systems in place that are proven and you leverage your team, because you can delegate a lot of this to your team members, I'm going to talk about that's one of the reasons why you can be more profitable. You can do this in under an hour of doctor time per case. I can promise you we've done it with lots of offices. Would you agree with those numbers there on that, Lisa?
Yeah, somebody that's been doing it a while could probably even shave it down to about 30 minutes or less.
In
So
my office,
yeah,
I do. And let me say this, that doesn't mean the patient's getting shafted here and not getting good care. I have
correct.
a really great team. They do really good job, and my patients are getting the optimal care. It's just that my team's doing a lot of it because you can delegate more. And as a dental sleep dentist, if you look at just these numbers, which I think are extremely conservative, you're making over double in most scenarios of your time from your most procedures. And I can tell you this as a general dentist, each of my offices grosses more than most general dental offices do. And per hour of my time, it's one of the most profitable general dental practices in the country. It can really make more per hour of your time because you can be more efficient. You can't do that doing molar endo unless you get really, really fast at the molar endo, because you can delegate a lot of this and you can provide a great service to your patients. So let's take that $2,000 figure and let's think about it. If you just saw one patient a week, you're going to add six figures to your gross income. If you did three, you're going to add 300,000. And Lisa, do you think 3,000 is a stretch? I mean, I still think that's probably within the average to maybe low average for dental offices, what they
Yeah,
collect per patient. Do you agree with
yeah,
that?
yeah. What we see across the United States about our with our offices, it's usually somewhere between about 2,800 and about 3,200. So you're right smack in
All
the
right.
middle of what we see.
Yeah. So you want to look at the low end or maybe what's more average. If you added three patients a week, you're pushing as much as a lot of dental offices gross per year. So
Right.
I'm going to tell you something. There's nothing you can do to be more profitable than doing this in your practice. So I think when we marketed this course, we're talking about this can be profitable, but you can also help patients. And why it's more profitable is you have lower overhead. You
Hmm.
don't have to buy a bunch of fancy equipment for this. Delegation, delegation, delegation. And that doesn't mean poor service. That means great opportunities for your team. They can become really important to the patients. They can do a phenomenal job. And everything that you can legally delegate, you can help more patients because your team can do a lot of it. And then there's almost unlimited patients. We're going to go into that in just a moment. 54 million Americans have obstructive sleep apnea.
Mm.
There's not, we're not fighting over the same patients here. And it really is going to equate to the end of the day. You're going to make more money per hour as a dentist if you do that. I hope that's not the only reason that you do this. I hope you do it because in addition to saving teeth, now you have an opportunity to save, extend lives, make patients' lives far better than they used to be, and really do something very impactful for your patients. So that's the fun thing about this. And, do you have to choose between these two? Well, the good news is you don't. If you understand airway, I will tell you this, I don't have time to get into this tonight, but once you understand the airway and the impact on bruxism, overall health of your patients, you'll actually grow your dental practice and make your dentistry more predictable once you understand the airway. It's a big puzzle that you might be missing, a piece to your puzzle that you very well might be missing. So getting involved in this there's just really a lot of reasons to do this. I'm going to pause just for a second. In a moment, we're going to show you a video of a patient having sleep apnea. But before I pause and show that video, I do want to emphasize everybody doesn't have to be involved in dental sleep in their practice. If you're a dentist, you may not choose to do this, and that's fine. I think you can and you should, and I think most of you will want to. But if you don't, at the very least, if you leave this webinar with nothing more than this, I hope you'll leave with the understanding and belief and maybe even obligation that you need to be screening your patients, looking at them and seeing who's at risk for apnea and helping them find help to get diagnosed and treated. And I'll overview how you do that in just a few moments. So again, we have a chat there. Lisa's monitoring it. We're probably going to answer most of the questions at the end. Is there anything that's pressing we need to get to, or should we jump into the video, Lisa?
There's nothing pressing. I do have one question. The question is there any specialized training required for dental sleep medicine? And if so, where can I find out more about it?
Well, Lisa, it depends on the state. Some states do require you have certain amounts of CE. American Academy of Dental Sleep Medicine provides some of these trainings, and then courses like I teach, and then you can get at Dental Sleep Solutions will help you with that. And if you'll answer the emails after this, we'll direct you to where you can get some help to do this.
Perfect.
So I'm going to show you a video of someone having apnea. It's kind of an older video. I probably need to update this, but I've been using it for a long time, so it shows the point. I want you to think about a couple things when you watch this video. I want you to think about, if your patient has this and they're in to have their teeth cleaned or a crown or whatever you're doing for them, what is more important for you to do than let them know that they may have this problem? Because most people don't know they have it. As maybe 10%, maybe 15% of people actually know they have apnea. Far and away, most people are totally unaware they have this problem. So what would be more important than you could do to help them know they have it and help treat them? Is there anything more important to that patient's life as you watch this video? And then we'll also talk about all the devastating effects. We'll talk about what apnea causes in a little bit. Just think about all the health ramifications of this problem. And we'll talk a little bit while the video is going on about what's actually happening. So here's the video. Can you hear the sound, Lisa?
Yes.
Okay. So the patient's snoring here. Okay. And as he's snoring because the airway is narrowing and less air is moving quicker and it's getting constricted. Okay. And that's why he's snoring. So snoring's an issue in and of itself. Now he quit breathing. Almost quit breathing. It's barely getting in the air. Now I want you to look at his chest. Watch his chest go up and down here. And what's happening here? He's trying to breathe, but he can't because he has a cork in his throat. He's got a blockage in his neck. Think about what's going on with his blood pressure, his heart rate. You think he might have a headache in the morning? You think he's going to feel good? And do you think it'd be important for you to help this patient understand that this is going on? Then what happened right there? Why didn't he die? Something happened. He's not awake. He doesn't know he's doing this. He took some breaths. Okay, looks like he just ran a marathon, right? And then he goes and does the whole thing over again. So
Wow.
in that video, I'm going to kind of quickly explain what's going on there because I don't have time to go into our whole 2-day course here on it, but it's really not that complex of a problem when you think about it. When we fall asleep, and if you can follow from the sleep here and go clockwise with me as I go around this, when you fall asleep, our airway narrows because all of our muscles start to relax. And as the airway narrows, the air gets squeezed and less air moves quicker, just like if you blew through a trumpet. And it starts making a noise that we call snoring. So snoring is a sign of a bad airway. And eventually it closes off to the point where you don't breathe. You saw his chest going up and down. And then the patient becomes hypoxic, where they're not breathing at all. And the patient's oxygen goes down. Now, there's where the critical part comes in. The patient, at that point, his body has to choose between sleeping and breathing. And eventually he says, hey, I want to breathe more than I want to sleep. And he has an arousal from sleep. So he goes from deep sleep to light sleep, not to awake. His muscles contract and the airway opens and he starts breathing again. And then the whole thing starts over. So quite simply, it's when the atmospheric pressure pushing in on the airway is greater than the muscles pushing out and the air in the airway pushing out, and we have a collapse. And I think this particular slide I want you to look at. If you're eating dinner or not paying attention, wake up, pay attention to this slide because it's important. Everybody that's in the dental field probably knows this is the tongue. Most patients don't realize how big that tongue is. If that tongue had oral cancer on it and we didn't see it as a dentist as they came in to have their teeth cleaned, we would be remiss. Would we have not? Do you think we might be in trouble, Lisa, if we didn't catch that?
Yes, absolutely.
And so here's where it comes in that I want you to pay attention. So wake up, pay attention. At night when this patient falls asleep and this happens, whose job is it to tell the patient, hey, you're at risk of this happening? The primary care? I mean, who's, because they're not doing it. No one's doing it. It's very undiagnosed in our country. I'm going to play that one more time. So look up for a moment again and pay attention to this slide. That's what's happening at night. And it's really, dentists are in the best position to have a discussion about this, because we know the anatomy, we understand retrognathia and all the stuff we can go into in the in further education about who's at risk for this. But just trust me, dentists are in the best position, and so it really is our job to tell them that if they had oral cancer on that tongue, it would be our job. And if their airways get blocking like that at night, it's our job to help them. Now, if someone gets diagnosed with apnea, they finally know they have it, they're not in the 10 or 15%, someone gets to them, they actually have a test, they have apnea. There are only 2 recommended first line of therapy treatments by the American Academy of Sleep Medicine. That's the physicians, not the dentists I'm talking about. The dentist groups agree with it, but the American Academy of Sleep Medicine say there's 2 options. Well, everybody knows one of them CPAP, but did you realize that dental devices are the other recommended first line of therapy? And notice these are side by side on my slide. When I started doing this 20-something years ago, and if you come to one of my lectures, I'll probably say this 100 times, you don't know how good you have it. Because when I started doing it, CPAP was first and then dental devices. Actually, it was CPAP surgery and then dental devices. But now we realize dental devices work really well. And it's within the standard of care. If you have apnea, those are the 2 choices. All these other things you can do, Inspire surgeries, positional therapy, they're either adjunctive or after you've tried the first line of therapy. So we're equal to CPAP nowadays. Maybe some insurances, if people have severe apnea, might dictate us trying to CPAP, but in general, dental devices and CPAP are the 2 solutions for this significant problem. So I'm going to talk about the 2 separately, then I'll pause if Lisa has anything to add. So what does a CPAP do? Well, we have this blockage here, right? There's a blockage in the back of the throat. And what a CPAP stands for is continuous positive air pressure. Okay, so it is a pump that basically blows this collapsing balloon open. It's not oxygen. It's not some fancy air we're blowing in there. It's just ambient air that is pressurizes the airway from collapsing. That's what CPAP does. What do dental devices do? Dental devices stabilize the lower jaw, or the mandible, as you know as dentists, and it keeps that mandible from falling back like it's showing here, and it keeps it at a forward or a normal position oftentimes, just to keeping it from going back. And the vast majority of the time, it makes a much more open airway. And the benefits to dental devices over CPAP are a lot. It's more comfortable. It's more tolerated. We can adjust them. Affordability is equal to or less than CPAP over time. And it's becoming just as effective or more effective for mild to moderate, and becoming a secondary treatment for severe apnea. So overall, it's becoming as effective as CPAP. And how it works, there's a lot of different devices out there you can do, and we're not going to talk about that today. We can talk about all the device selection. They all work, and they all have some bells and whistles that are better. But how do they work? This is an old slide. I want you to look at the blue as the concentrate. The blue's the airway, the red's the tissue, and the white's the mandible. And they did this on sedated patients. They did an MRI, and then they pulled the jaw forward. And I want you to look at the airway on the right side if they pull the jaw forward. Look how much wider it is laterally and anterior posteriorly. So when you pull the jaw forward, or keep the jaw from falling back with a mandibular advancement device, it 3-dimensionally usually opens up the airway. And that's where we come into play and why we can help so many patients with this. Lisa, do we have any questions that do we need to get to before I jump into more prevalence here?
Yeah, so we do have one question and one comment, which I feel like the comment feeds back into exactly what you're talking about with the delegation. The comment is it's also really important to have dental hygienists evaluate the patients by asking questions during their care. So myofunctional therapists are also good as well. We absolutely encourage the hygienist to get involved, because when you have the patient's mouth open, you're seeing a lot of things and you can absolutely evaluate. So hygienists play a very important role in all sleep apnea treatment. Delegation and reliable team, it's absolutely imperative to have in place. So one question that we do have, or actually we have 2 now, it says, do you send patients home with a pulse ox to use at night to catch anything that or they must have already had a sleep study? So I think we'll get into that a little bit.
We'll get to that in just a little bit.
Yeah. We'll answer that one live too.
And that we don't use pulse ox as much as sleep test anymore, but I will get to that. Did I mention you don't know how good you have it? I mean, it's so much better for dentists now than it was 23 years ago when I started. So a lot of things have changed. I only have an hour. You could tell how excited I am about dental sleep. It's just such a wonderful time for it. And I can get to those questions and tell you why you have it so good. Again,
Yeah.
1 in 5 adults has this problem. I want you to remember that. It's a huge number, 20% of the adults. We're talking about adults here. We could do a whole nother 5 hours on children. So most of the thing we're talking about today is adults have 20% of obstructive sleep apnea. And this study is just a couple of years ago, over 1 billion people globally, but our country's like one of the leaders. We're winning. We have as many per capita with apnea as anywhere about in the world at 54 million Americans. I mean, that's a large number. And of those, almost half of them, 24 million, have at least moderate apnea. So these aren't just people with just fairly mild apnea. These people have significant apnea in our country. It's a big problem. And less than 10%, some studies say 15, so we'll say 10 to 15% of the people know they have it. 85% or more don't know they have it. They're walking around, taking blood pressure medicine, tired, have all these comorbidities that I'm going to go to in just a few moments. And when you look at this, I believe it's an epidemic, because when you figure out that maybe 15% of people, 10% of people know they have it, and then once they know they have it, most of them aren't successfully treated. Somewhere south of 10%, probably 2 to 3% of the people in the U.S. who have apnea are actually successfully treated. And you can play those numbers around, but it's certainly somewhere south of 10%. And do you think that that's a good opportunity for us when there's so many people to have this, and only 2 to 3% of the people are successfully treated? Billions of dollars are spent on CPAP. What do you think the dental market is? It's huge, because a lot of the times the CPAP fails, which we'll get into in just a second. So here's where I say the most bold statement I ever say, and I've said this to tens of thousands of people, and no one's ever corrected me on this. Obstructive sleep apnea is one of our country's most significant undiagnosed, untreated medical disorders. I'll say that again. Obstructive sleep apnea is our country's most significant undiagnosed, untreated medical disorder. There's nothing else that we have. I kind of tailored that when we had COVID. COVID aside, COVID's kind of in the past now, hopefully. Today, currently, there's nothing else that's this prevalent, 1 in 5 adults has it, that most people don't know they have it, so it's undiagnosed. And once they have it, it's not treated. 2 to 3% of people are treated. And it's decreasing patients' lives. It's decreasing patients' enjoyment in life. Now, CPAP's what most people are given. A lot of times without any fanfare. You have apnea, here's the treatment. They don't go into dental devices. It's getting better. We can talk about that in the chat afterwards if you want. But CPAP works fairly well. You put this pump on and blow the airway open, it works. But the problem is that you have to wear it. And CPAP's gotten a lot better over the years. I think that when you look at the masks that we have, they're much better than they were. We got smaller ones here, and we got humidifiers, as you can see, kind of in the back here to make it better. We've come a long way since some of the first masks. I mean, hey, let's pat ourselves on the back for that. Even my own patients. This was my patient about 20 years ago in my office, and I took a picture of her CPAP. That was the state of the art back when I first started doing this in my office. And you could just see, does she look happy, Lisa? She look excited to have that thing on?
Scared.
I didn't tell her. She's not an actress. I said, hey, can I get a picture? I was doing one of my first lectures. This has been over 20 years ago. I was giving a lecture to a bunch of physicians up in Tampa. And I'm like, you can see my little dental figurine in the background. You even see it there. And I'm like, let me take a picture. And she was just terrified putting this thing on her face. And again, CPAP's big money, folks, billions of dollars. So this was an ad I found on the internet. So think about this. They went out. The marketing team, they hired actors and actresses. They hired a photographer because they're going to sell you their product. And they took this picture and they said, let's do this. Now, I don't know, Lisa, do you sleep with your glasses on?
No, not intentionally. Not intentionally.
Excuse me. So I found that to be a little bit of a flaw in this one. So I feel this one's a little better. I've been using it for quite some time. A lot of you dentists are good photographers, so you got the aperture just right here. You've got the faded wine or whatever this is in the background. We look like we're at the Ritz-Carlton with all these nice sheets. But what the heck is this? I mean, this is an ad intended for you to go, oh, I want that. Let me dish out my money and and let me go get this thing for you. So that's our competition. And here is the real fun part is once a patient comes to the realization that they have apnea and they have all these risks associated with it, I'm going to go into in just a minute, all these bad things that can happen to them in addition to not feeling well, they have two choices. Again, it's not CPAP then this. There are two choices according to the American Academy of Sleep Medicine are, hey, you can have this CPAP or you can have a dental device. Which one would you rather have? I mean, isn't this a fun thing to talk about in your office? I don't know, Lisa, you weren't involved in dentistry before, but back when I ran my dental office, I spent a lot of time saying, hey, you need to have a crown. You need to have a root canal or whatever. And people go, oh, I don't want that. We as dentists spend a lot of time trying to get patients to do things that they don't really want to do. What's really nice and enlightening about this is once someone realizes that they have apnea and they want to treat it, which one are they going to choose? I mean, they'll beg you to, I hope this thing works for me. I have people coming in so excited that they know that there's an option other than the CPAP. And I can tell you, I've been treating myself for over 20 years, ever since I was that young. You can't see me now, but I don't look like that. I have a little more gray hair and a little less hair. But I've been wearing a dental device. That's a picture of me back 20-something years ago for 20-something years. And I just had all my blood work done, I'm 58 years old, going on, 59? And, all my blood work's good. And I really believe a big part of it is that I sleep well and I treated my apnea. I'm really thankful that I got involved in this. And Lisa, by the way, one of the cool things is I saw my very first patient today.
Oh, really?
I meant to have her come. I meant to drop the picture in here, but my very first patient I saw 23 years ago, the first patient I ever treated, is still wearing a dental device successfully. She came in for a recall today. I should have dropped this picture in here. I've been treating her for 23 years, and she's doing great. So I took a picture of her. She's 81 years old now.
Oh, wow.
And it's very, very rewarding. So we're going to talk about the risks associated with apnea, but I'll pause for a moment and see, Lisa, do you have any questions that we need to interject here rather with?
Yeah, the only one that came up that I think that I know you'll probably be covering some of the other ones, but what happens if TMJ when the jaw is pushed out pushed out during the sleep with the sleep appliance, and do a lot of patients complain with discomfort?
That's a great question, and I know a lot about TMJ. I've had a lot of training in that area. Excuse me, and I could go into my training if you wanted to, but the short answer is most of the time for joint problems, these things help because it unloads the joint. We actually make, and I have made, mandibular advancement devices, which, by the way, these things we make at night that keep their jaw from falling back, we call them dental sleep devices, mandibular advancement devices, mandibular repositioning devices, dental orthotics. We're all talking about a mechanism that keeps the jaw from falling back. One thing that's a misnomer, Lisa, is a lot of people think that we protrude the jaw always.
Right.
Most time we start by just keeping the jaw from falling back and closing off the airway, and that makes a big difference. A lot of the TMJ problems are caused from malocclusion and distalizing contact, shoving the jaw back into and compressing the joint. We unload the joint by moving it forward. So oftentimes these can actually help most types of TMJ problems. And the other type of TMJ problems people have are are sore muscles. And that's caused from the bruxism. And people who have apnea brux their teeth 2 to 3 times more likely than people who don't. And there's a cause and effects for bruxism from apnea. And once we treat the apnea, the bruxism goes down. So the short answer is most of the time we improve TMJ problems over causing problems. Yes, there are people that get muscle soreness. So yes, there are people that get some jaw soreness out of this. It can usually be worked through. And in 20-something years, I don't know if you can hear me knocking on wood there, I've never had it be a permanent problem. Worst case scenario is this doesn't work for them. And that's, something that does happen occasionally. But the vast majority of people, if you know what you're doing in today's world and you don't get too carried away by trying to move the jaw too far too fast, which we don't have to do because you don't know how good you have it, because we have some really good testing ways now that I'll explain in just a moment. Yeah. Any other questions on that, Lisa?
Yeah. Well, one more I think that may fall into here as well, and I don't have enough dental experience to explain this. So, are MAD devices effective if apnea is caused by enlarged tonsils or adenoids, or do you refer to an ENT first?
Great question. We always do an exam. That's part of what we teach you if you've, come to any of our more advanced courses. You look at that. We have a discussion with the patient, let them know that. But the answer is no. Well, yes, I don't know what the question was, but let me answer the question is dental devices work quite well, even when they have enlarged tonsils, in particular adenoids, because it stabilizes the jaw forward. There are times where we get a certain amount of resolution with the mandibular advancement device, and then we go back and say, you know what, we want to make this a little better. Now let's consider doing the tonsils and adenoids. We don't do it first anymore, because it used to be the standard of care. Used to be it was when I started, back when you had it a lot worse than you have it now. If people couldn't wear a CPAP, they had to have a tonsillectomy. What's a procedure called UPPP surgery first, before they would even qualify for a dental device, oftentimes for insurance reasons. Now we realize mandibular advancement devices work far better than those surgeries on average. So we do the surgeries after if needed and indicated. After and if indicated. It's a great question. So everything here on the screen, we can spend hours on each of them, is directly made worse or contributed to by obstructive sleep apnea. In other words, apnea can cause us to be at a lot higher risk for a heart attack. It can cause us to be a lot higher risk for hypertension. It actually can cause the hypertension. Once we treat our apnea, these things on your screen can oftentimes get better. Well, maybe not cancer. Well, I'll talk about that one separately. But diabetes, reflux, even male impotence can be caused directly by the apnea. Cancer is from the desaturations that we're starving our body from oxygen. And people who have oxygen desaturations, especially at night when they're asleep, are much higher risk for cancer. We could go into the mechanism behind that. And actually, obesity is not only a risk for apnea, apnea can cause obesity. So, I mean, all these things you don't want. And if you can put a mouthpiece in your mouth to help minimize your risk for these or decrease the amount of hypertension you have or impotence, I think or having an automobile accident, it's really worthwhile to treat that. There's a lot of studies out there. We can spend 45 minutes just on some of the more prevalent studies that we talk about. This is the one I like to use when I only have a little bit of time. So, and I use this with my patients, by the way. When we do consultations, we talk to them about this Wisconsin sleep cohort, which started back in 92. They took about 1,400, I think was the total amount, of state employees from Wisconsin. They say, hey, we want you to volunteer for this study. We're not doing anything but do a sleep study. That's it. And then we want you to come back about every 7 years. If you're still alive, we're going to repeat the sleep study and see how you're doing. And so what they found over about a 20-year period was this top line is people who don't have apnea. They found that after about 20 years, the majority of those people were still alive. And by the way, I print these out and we kind of go over this with our patients. And then we found the people had mild apnea. Well, with no treatment, there was a difference in these over 1,000 patients, that there was 3 or 4 or 5% difference of the number of patients who were still alive 20 years later. And then when you jump down to moderate apnea, wow, there was a notable difference in that, over a 10% difference in the amount of patients who are still alive. And then, my gosh, when you go down to severe apnea, you're pushing half the patients weren't still around. So it's a really big difference in the number of patients around that were affected by this apnea that they believe, because these patients had all kinds of other problems, but they just looked at the apnea. And so when we do dental devices, they work. If we look at what's called the HOCMA study, when we take severe apnea, 69% of the time we can move them from severe to mild to moderate. I don't have it on the slide, but a little less than 1 out of 3, 31% of the time we can move them up to non-apneic. And here's where we really shine. 84% of the time, according to the HOCMA study, which I could give you the citation on that if you needed, it moves patients from moderate or mild to non-apneic. So these things work great for mild to moderate apnea. They work quite well for severe apnea at reducing the apneic load, is what we call that. And it's important, because it doesn't matter who you are, how famous you are, how much money you have. It affects everyone. These two people died, and in the papers, they talked about there was an associated or non-treatment of apnea contributed to their death. Carrie Fisher, she was found asleep that wasn't wearing her CPAP, died in her sleep. She had some sedatives that night, and they that sleep apnea contributed to her death. Judge Scalia had his CPAP machine beside him, but it wasn't plugged in.
Mm.
And he died in his sleep as well. All the affluence of these people, and maybe they could have been helped had someone talked to them, had their dentist screen them, had their hygienist said, hey, you're at risk. And then once they did that, they found that apnea, instead of said, hey, if you can't wear that CPAP, come back. We have a solution that might help you. And I can tell you, I have a personal story about this of over 10 years ago. A patient, not a patient, but a person I know from the gym. I saw him all the time in the gym. And he was a fire chief in the local fire department. Hey, chief, hey, doc, he'd say to me. One day he came up to me and said, hey, doc, I see you treat sleep apnea and I can't wear my CPAP. Can I come see you? And I said, sure. Let me go out to my truck and give you a card. I went and gave him a card. I said, come in and see me. Well, he never came in because in a week he was dead in his early 50s. And this is right out of the paper from whenever this was, 2011, that, he had apnea. He'd had his tonsils, Lisa, cut out and uvula, because that was back when they did that. And he died, had an 11-year-old son. It was a shame. He never got in to see me. So that's how significant this is. And the ADA says you should, in fact, be doing this. At the very least, you should be screening your patients. SRBD means sleep-related breathing disorders. So to paraphrase this slide, you as a dentist are at the best position of all healthcare providers to look at your patients and say, hey, who's at risk for this? And if you're at risk, let's do something about it. Let's get you tested. And then we as dentists can actually help facilitate that testing. And I'll get to the question about the pulse oximeter in a minute. And then once we treat the patients, we as dentists should be the only ones really treating these patients. And I can assure you, physicians shouldn't be doing this because it's too involved with the teeth. And then we should be able to use portable home sleep tests to monitor them. So this is Guy Yatros or Lisa Hertz saying this. This is the American Dental Association saying, you're not doing your job if you're not at least screening your patients and getting them help. So that's a significant thing. And so why should you do this? It's the right thing to do, but also it is your job to at least screen. So I'm going to talk about what we call the 4 pillars pretty at a high level, just for 5-6 minutes. We'll have questions. And so, Lisa, maybe unless there's something pressing, maybe I should do that. Or is there a question now that we should get to before? I think we got like 12 minutes left. So
there's nothing pressing.
Okay, we'll get to the questions. I'll be finished with this part. This is a really fast overview of what it means to brings dental sleep medicine in your practice. Now, trust me, can't get into all the things on here, but I can promise you, if you want to do this in your practice, you just need team members and systems to screen all your patients and see who's at risk for this, and then get them tested, which is much easier than it used to be, get them treated, which is much easier than it used to be, and get paid for it. And we have systems for all this to fill in all the gaps of these 4 pillars. Because if you put these 4 pillars in, we've helped thousands of offices do this. And it's not for lack of need. 54 million patients need this. And in order to be successful, the number one thing you need to do is believe it's your job to do it. You've got to believe that this is worthwhile. I'm not just trying to sell somebody on the new cosmetic procedure. I care about my patients. I want to help them. And I want to help them prevent this terrible thing called obstructive sleep apnea they have. And then once you do that, you just got to have a system in place to do that. Now, I can't make you believe this, but we certainly can help you with the systems with some follow-up courses and things down the road. So I'll talk about each of these pillars pretty quickly. Screening is simple. We have great computer systems now. There's all kinds of questionnaires you can use. It's as simple as asking your patients some questions. Maybe looking in their mouth too can help, but it can be done in a matter of minutes. It can take less time or equal time as an oral cancer screening. And it can be, a lot of it can be done with questionnaires. We have some computer programs that are really interactive that help with them. And what we look for when we do screening are things on their medical history, and then we look at things in their mouth. We look at there are risks for all these things. You can see some numbers in parentheses. That just means that they have high blood pressure. I can find you some studies that showed that 30 to 37% of the people who have high blood pressure also have apnea. 48% of the people who have diabetes. AFib, at least half of them do. So you can see how the screening works just from the questionnaire. And then here's where we really shine. As a dentist, we can look at their neck size. We look at their tongue. We can look at their craniofacial anatomy, whether they're retrognathic or have long lower faces. We can talk about why all those things mean this patient's at risk for apnea. Now you tell me who else is more in a position to look at these things and say, hey, you know what? You're at risk for having apnea. Let's find out. And here's where, again, you got it a lot better than I did to start with. The testing. When I started doing this, the only way to get the patients tested is, yep, Mr. Jones go, yeah, I want to find out. Well, great. Pack up your jammies and go down to the sleep lab, and they're going to let you have a really restful night's sleep while you wear all this garbage. Okay. That was the standard of care. It's called a polysomnogram. Good news is you don't have to do that anymore. There's sleep tests now that are simple as putting a thing on your finger or somewhere in between. Most of them are done at home now. And dentists can be involved in that. So I can't get into the pulse oximeter question in detail. We can use those, but why do that? There's home sleep tests now that in most states, dentists can facilitate testing. There's insurance reasons that you may or may not want to do that. We'll go into all that at some point if you want to learn more about doing this in practice. But the good news is testing can be done at home. It can be very simple, and dentists can be involved in facilitating in most states, or at the very least, they can help coordinate with a doctor to do this. So it's not this anymore. It's more like this. So the testing is so much easier, less expensive. There's really no reason to say, hey, Mr. Jones, I think you're at risk for having apnea or airway problems. Let's send you home for a few $100 or your insurance will cover it. Let's find out. And then the treating, gosh, this is where you really don't know how good you've got it, because we can talk about the devices you put in and the exam and all that stuff that we do. But really the hard part of treating is once you give them the device, you just start at a very conservative spot. We used to start way forward, put it till the patient's, it hurts. All right, that's far enough. We don't do that anymore. We basically start the device at what we call their MICO, pretty much at their functional occlusion, and just keep their jaw from falling back. And the reason we can do that is we have something that I coined. I'll pat myself on the back. I started doing this a few years ago with pulse oximeters, but now we have these sleep tests that this is a level 4 sleep recorder that we use in my office now, and there's other ones out there that you can use. We give this to the patient, we start them in a comfortable position, and then they move their device to multiple places over different nights. So each night they move their device a little bit different place. Within a week, I've got a lot of data to be able to tell, hey, where's the best position for their jaw? So we're doing a far better job of calibrating these devices. There's some learning curve, just like anything else to it, but we're just doing a far better job of calibrating these devices than we used to. And it's so much easier. And these devices aren't that expensive. I just bought 18 of them because these are the newest ones out there, and they're $300-$400 a piece, something like that. And it's revolutionized how I do this in my office. So that's become easier. And then the billing's become easier. Billing is all medical billing. It's not dental billing. This is not billable to their Delta Dental. Now, Lisa could talk for hours about this. That's her expertise. But this is medical billing. You bill your medical insurance for this. And this is how I used to feel when I first started doing this. But nowadays, there's experts out there. That's all they do is medical billing. So there's really no reason not to get involved in this. So I think I have time for this poll. I'm going to do it fairly quickly, and then we'll answer some questions, or if that's okay.
Yeah.
I want you all to answer this poll for me. And if you found someone who you felt was at risk for having apnea, I want you to be honest with this and tell me how likely you are to get that patient to go and get a sleep test. There's 700 and something people on here. How likely, if you saw someone and they're at risk for this, how likely you are to get this? I'm going to do this fairly quickly, so do it in the next 5 seconds because I want time for questions with the remaining 5 minutes. All right, I'm going to give you 3, 2, 1. And I know that's a little hard because some of you might not be doing dental sleep, but can you all share results here? Here you go. Can you see that, Lisa?
Yes.
Kind of across the board, maybe 28% say, yeah, I'd get that patient to go for a sleep test, and maybe 20% say no. So it's kind of evenly spread across the way. So I'm going to stop sharing that, and I'm going to go fairly quickly since I don't want to run over. Now, the next one is more up most dentists' wheelhouse here. If you saw this patient come in your office, and they're a smoker and fisherman or 50 years old, how likely are you to get this patient to go and have this evaluated for oral cancer? Can you see that?
Yes.
Lisa? Okay, great. I'll give you about 7-8 seconds on this because I don't want to take the whole night on this poll. I'll give you a countdown of 5, 4, 3, 2, 1. I'm going to end the poll because this is always the way this works. Wow. Look at that. Almost 100%. You know, everybody's like, yes, God, this has to be gone look at. And I get that. And I understand why you feel that way. But let me explain this to you. And if you want to get involved in this and you fully believe that this is my job to tell this patient that, trust me, this is as deadly as most oral cancers. It's probably more deadly than most oral cancers. Once you fully believe, I'll back that up. Told you it was an important slide. Quit eating your dinner. Pay attention. Here we go. Look at this. There you go. When you look at that, that's my job to do this. And when 91% of you say, yes, I'm going to get that person to go, and you really believe that this is my job to do this, bringing dental sleep in your office is a cakewalk. All you need to do is believe it's my job. And I know it's the first webinar, maybe some of you had. Then we can walk you through these steps that are simple compared to doing a crown or two-surface composite. My God, that's hard to do. Certainly a root canal. I can't even do a root canal. Never was good at that. This stuff is simple once you believe in it, and we can help you. And it's not all roses, but let me tell you, it's a lot more fun and a lot more rewarding per your amount of time, and you'll make more per hour if you do it correctly than doing dentistry. So just adding it in can give you some real enjoyment in your life. So here's how you get a hold of us. Dental Sleep Solutions. I think I have one more slide here. There we go. That's who you want to get in touch with. Lisa, is that the you want me to leave up?
Yes, please.
Okay, and finished under an hour, and we're going to answer some questions here. So
absolutely. So I have a fellow Pankey person that's on tonight. She went to a Pankey course. So she said, some dentists are concerned about changing the bite with mandibular advancement device. What are your thoughts? She recently took a Pankey course and it was discussed, specifically mentioning fluid buildup in the TMJ and the condyle not being able to go back into position for a couple of hours. What are your thoughts?
I'm going to tell you a story about Rich Drake on this. He's a partner helping start Dental Sleep Solutions. First of all, yes, bites can change on this. And I will say I've seen bites change, and rarely do I see it become any real problem with the patient. Rich Drake went and talked to a bunch of physicians, and he was talking to them about, well, this causes changes in the bite. And the physicians were all kind of laughing. He's like, what are you all laughing about? He goes, you're really worried about someone's bite changing a little bit? Most everything we do in order to help patients' lives, one of the side effects is like death. And, you know, our side effects are far worse than that. So, yes, it is a side effect, but I think us dentists focus so much on the bite that the risk of that, there's great ways of preventing that today. And it is a possibility. I don't want to minimize it to nothing. But compared to not breathing, malocclusion loses. Right. Let's just say that. And I can tell you, in most cases, if the bite does change, it doesn't hurt a darn thing. I used to think occlusion was the most important thing in the world. I really believe if you don't grind your teeth at night, it's not near as important. But no one's going to argue it's more important than breathing. And these people just aren't breathing at night. So I think there's ways of working through it. Please, please, please don't get them. Don't write this off because you're worried about that. I care about patients' overall health. I care about their bite. It rarely becomes a problem. What else we got, Lisa? Sure.
So what are your thoughts on laser therapy, like night lays and things like that?
They're adjunctive. I mean, laser therapy, just like removing the tonsils, other surgeries, it can stiffen up the palate. It can help residual snoring after you actually treat the apnea. So it makes the soft palate more firm. As a overall treatment for the majority of apnea patients, it's going to move the needle very little when you look at apnea as a whole. I mean, if maybe really mild apnea, it might help. It's a decent adjunctive thing. But, you know, if laser surgery, let's go back to, they used to remove the whole soft palate.
Right.
And the uvula and the tonsils. And that was far less effective by about half, less than half as effective as dental devices. And the whole soft palate's gone. So, I mean, making it a little more stiff is not going to move the needle as much as dental devices, but it's a nice adjunctive thing. If you have one of those lasers, it can help residual snoring, and it can help some of the really mild cases or some of the people who just snore and haven't met the criteria of apnea yet.
Gotcha. We just have a few more questions. So, what about patients without teeth?
Without teeth, it becomes more challenging. Now, if they don't have upper teeth and lower teeth, you can do a mandibular advancement device. Don't make it your first case. Okay, it's a little more challenging, but we do have ways of doing it. If they have no teeth, there's something called a tongue retaining device you can do. But if they have implants, it's fine. So yes, we do hook these to teeth, and so you've got to have teeth.
What about dentures?
Upper denture, there's a way of doing it quite predictably if it's an upper denture with lower teeth, but lower dentures, no implants, it's very challenging. I just don't do it anymore. It's very hard to do, but you can do a thing called a tongue retaining device.
Okay. All right. Looks like we've answered most all of the questions. What do you say when patients ask about less evidence-based treatments like Vivos, DNA, mRNA, and etc.?
You know, I just refer them back to the American Academy of Sleep Medicine, American Academy of Sleep Medicine. I mean, you know, some of those may turn out to be good for some patients down the road. It's not a fast treatment, so that much I know. You know, from what I know about it, you know, it's a pretty involved treatment. And so, you know, the American Academy of Sleep Medicine, American Academy of Dental Sleep Medicine, first line of therapy are dental devices or CPAP. If both of those don't work, then we need to look at other things. I don't think that we should be doing Inspire or MMA surgery or maybe these other types of treatments as a first line of therapy. It also depends on the level of apnea and so forth.
Okay, perfect. All right, I think we've covered just about everything. So I just want to let everybody know Dental Sleep Solutions sponsored this for tonight. We appreciate the opportunity to do so for Dr. Drake. Or I'm sorry, Dr. Yatros.
Thank you.
You said his name and made me think about him. We really appreciate the opportunity based on Viva Learning as well. It's been a pleasure to work with them. So if you have any questions, you can reach out to me at lisa@dentalsleepsolutions.com. We do host other webinars and events. We have a long laundry list of those that you all will be included in as well if it's something that's of interest to you. You will receive a 3-question questionnaire, I guess is a really good word for it, after this event. If you're interested in learning more or even have questions, please fill out that 3 questionnaire. We'll be reaching out to you. You can reach out to me directly and I will get you to the appropriate person or be glad to answer any of your billing questions as well. So I'll be glad to take care of that. And we just have really enjoyed the opportunity to be here tonight and present this information. This is a Dental Sleep Medicine 101, so we will be looking at adding other opportunities as well for future webinars. And Dr. Yatros, I want to thank you so much for doing this.
Sure. And I want to emphasize too, if you want to come to any of the in-person course, including the one that I think that I'm doing in October in Vegas, reach out to Lisa. She has information on that. We'd love to meet some of you in person at that day. It's like a day and a half course there. Well, it's an evening and a day, but we'll have a great opportunities for a lot of hands-on learning, and we'd love to meet some of you there.
Yeah, too. We're also having some events in Clearwater, Florida, Bradenton, Florida. We're going to be in Missouri, Dallas. So we're taking our road trip. We're taking it to the road, so.
Right. Well, sounds good. Thank you, Viva, for having us, and thank you, everyone. If we can ever help you, let me know. And I think that we're good to go then, right, Lisa?
Yes, everything is good. Thank you so very much. Have a good evening.
Good night, everybody. Thank you.
Night.